Hello and welcome to part 3 of chapter 14 on the liver. We had just finished up part 2 looking at late stage cirrhosis, and we are moving into other manifestations of chronic liver diseases. I'm going to show you a laundry list of different manifestations, and this is just so that you can have it all in one place. I have a separate slide devoted to each one of these things. Hopefully, with what we have talked about so far with normal liver function, it will become easier to see where all of these symptoms are coming from. In fact, we've already discussed where some of these are coming from, so we won't spend a lot of time on it. And then we'll wrap up the end of this lecture with a couple of other causes. We talked about Hep C, or the different viral hepatitis, and then we'll wrap up with a couple of other causes of chronic liver disease. So I'm not even going to read these here. I'm just going to go one at a time. Jaundice, that yellowing of the skin. The cause of it is, as you will remember, decreased conjugation of bilirubin. The bilirubin comes from the recycling, of the breakdown of red blood cells and the hemoglobin. The iron of the heme gets taken out, and then the other part is the so-called unconjugated bilirubin. In the liver, it's supposed to get conjugated and become more water soluble, and it can be eliminated. Much of it coming out in the bile, some of it going out in the urine. But in the case of liver failure, this isn't happening. And so the unconjugated bilirubin or indirect bilirubin builds up in the blood. So we see the yellowing of the skin and the increase in indirect bilirubin on the blood test. Another consequence of liver failure is bruising and bleeding. And we've talked about why this happens too. A reduction in the clotting factors. Oh, what we had said before was on a PT test, the clotting time, the prothrombin time is going to be increased. It's going to take longer to clot. What you can see on your patient is things that would ordinarily not have caused a bruise or wouldn't have caused bleeding out of the body is now causing bruising and bleeding out of the body because we don't have enough of these clotting factors to get down to make the fibrin, to make the blood clots. Another consequence is edema throughout the entire body. This one is tied to a decrease in the production of albumin, the famous protein that the liver makes. Largely what albumin is about. Okay, so this cartoon, here is this little tube thing is supposed to represent a capillary. And here are some cells of the tissue of, I don't know, whatever tissue you want to talk about. Let's pretend we're in muscle in the leg. The blood flow through the capillary. Clearly, some stuff is going to leave the capillaries. That's the way capillaries are supposed to work. But then stuff is supposed to come back into the capillary and continue on its way in the vein and back towards the heart. What happens here is because the oncotic pressure of the blood, and again, oncotic is the specific term that's used. It's the osmotic pressure that's due to the presence of proteins. And so if we don't have a lot of protein in the blood, we're missing a lot of this albumin that's ordinarily here that draws the water back from the tissues back into the capillaries. That water is going to come out of the capillaries and not come back in. That's what we call edema. And that's going to happen everywhere, as I said, specifically in the leg, but it's going to happen in the lungs. It's going to happen all over the body. All right, more consequences. Another set of proteins that is in short supply due to liver failure is the complement proteins. Those are needed for infection management. That's part of the innate immunity. And I'll remind you, one of the things when complement proteins attach onto the outside of virus particles or bacteria or toxins, it opsonizes them. It makes them tasty. It makes it more attractive to the neutrophils and the macrophages to take that stuff in. Complement proteins also act as chemotactic factors. They bring, they signal to the white blood cells that are circulating through the circulatory system. It draws them out of those vessels and into the tissues. And we don't have those complement proteins, so we don't have that signaling system happen. And then finally, that membrane attack complex, the grand finale of the complement cascade, that's not happening either. And so we have a difficult time fighting off bacterial infections, for example. All right, ascites. This one's a little bit trickier to understand. It can be traced back to the portal hypertension. And I will remind you, let's see, here's the liver. And these structures represent, for example, the stomach. It's been cut open here. The spleen. This is the pancreas, the duodenum. The blood vessels that recollect blood that's coming from those organs, that blood, all of it, before it goes back to the heart, has to pass through the liver, through the so-called hepatic portal vein. But if the liver is becoming fibrotic, those blood vessels are getting narrower, not as much material or not as much fluid can pass easily through those tubes. This is going to slow down transport through this organ, and we're going to start having a buildup of fluid, and that just backs up into the tributaries. As this backs up, remember pressure, the hydrostatic pressure, the push out of the blood vessels is going to be stronger than the pull in, especially because we have low albumin and we're not able to draw that fluid back in. So we have high pressure pushing out, we have decreased oncotic pressure pulling back in. Directly a result of this increase in pressure in the blood vessels flowing through the liver. Let's see. So yes, it's physically uncomfortable. The patient, this is a man, looks like 9 months pregnant. And you've heard patients talking about, they have this huge belly, it's pushing up on the abdomen, is pushing up into the thoracic cavity. The lungs can expand as well. One of the things that our patients report is not being able to catch their breath. They're not able to breathe enough. And then there's also edema going on in the lungs as well. I mean, so this is going to be a difficult situation for the patients. All right, another problem that again can be traced back to the hepatic, the portal hypertension, are esophageal varices and hematemesis. I know I have trouble saying that word, vomiting blood, in other words. So what's happening here is, again, we have, a slowed blood flow. I have it here, like it's blocked completely. It's just significantly restricted. And so there's this increase in pressure in these blood vessels. And so all of this pressure backs up and backs up and backs up into the vessels that are draining this distal part of the esophagus. Those veins increase pressure, that's going to swell. This is the inside of an esophagus, and this is a varicosity in the blood vessels on the inside of the esophagus. These can rupture, and the patient may start to vomit blood. This is an emergency. This is also something to consider. For example, if one is placing an NG tube, this is a risk of rupturing these vessels. And again, traced back to the portal hypertension. Yeah, I'll mention it in passing. We're draining the blood from the colon as well and back up the pressure. This can also lead to hemorrhoids, the development of varicosities in the rectum. Okay, and then finally, confusion for the patients. What on earth does the brain have to do with the liver? Why on earth would we have this confusion happening? Well, it comes back to the liver no longer being able to do something with the amino groups. Okay, back up. So the proteins are made of amino acids, and amino acids are called that because they have an amino group, which is a nitrogen and a couple of hydrogens. And so if we break down the amino acid, because we're going to use that protein for something else, we have to do something with those nitrogens. In the absence of any cooking, in the kitchen of the liver, if the liver's working right and we get to cook and we get to make something, we can put a couple of those ammonias together along with some other atoms and make urea, which is waste, but not completely toxic. If the liver is not functioning well enough to do that, then we get this buildup of ammonia. And that ammonia is really damaging to our tissues, especially in the central nervous system, where it interferes with neurotransmitter function and has some other effects. This condition where we have the elevated ammonia and the confusion, this is known as hepatic encephalopathy. And let me see. Oh, I should have been walking you through this here. So the amino acid metabolism. So we break off that amino group. What's supposed to happen is a couple of ammonias and some carbon dioxide get put together into urea. So here's one of the ammonia groups, and there's the amino groups. Here's the other one, and this urea is eliminated through the kidneys. But if this isn't working, if we can't do this reaction because the liver's not functioning well enough, then we just get more and more and more ammonia in the blood. And eventually it finds its way into the brain, and that leads to the confusion. The current treatment is not great, but it is the treatment that we have, and that is to provide lactulose. You may recognize the ose ending. This is a sugar. It's a disaccharide. It's a galactose and a glucose, I think. And anyway, we don't have the enzyme to digest this lactulose into those two monosaccharides. So lactulose stays in the digestive tract. And through mechanisms that I cannot describe, ends up decreasing the amount of ammonia in the bloodstream a little bit. It's not perfect, and it has significant consequences or side effects. And that is, again, we've talked about this before. We talked about it with lactose and people who don't have lactase. They don't have the enzyme to break that apart. If you have a sugar in the digestive tract and it stays in the digestive tract and doesn't get absorbed, that draws more water into the digestive tract and causes diarrhea, because you have more fluid coming into the digestive tract. And so although we're treating the patients with the lactulose to address the ammonia, we're creating this other problem where they're dehydrating, where they are making, they have severe diarrhea. And often we're not controlling the amount of ammonia enough to completely eliminate the confusion. So you have this confused patient with severe diarrhea. It can be a mess. Okay, that's enough about that. And this will be I think, our final slide, additional causes of chronic liver disease. We had talked about the hepatitis causes. Let's talk a little bit about alcoholic liver disease. This is one of the most common causes of liver disease around the world. And why it happens is ethanol is a toxin. I know we enjoy it and we ingest it on purpose, but our liver wants to get rid of it. And when our liver metabolizes it, it breaks it into something called acetaldehyde, which is really toxic to the liver. Yeah, the liver is just it's such a good organ. I mean, it's like throwing itself on the grenade, you know, it's like, oh, I'm taking one for the team. Yeah, so it's trying to detoxify this ethanol for us, and it breaks into these acetaldehyde, which is damaging to the liver. And so this leads to some altered metabolic pathways that are going to cause the liver to make more lipids, the fats, but it increases the fats that are being made, but it decreases the fats that can leave the liver. And so that promotes the fatty liver. So one of the consequences of having too much alcohol is the liver becomes enlarged with fat. Additionally, because of the damage that we're doing with the acetaldehyde, we end up with inflammation. The stellate cells, those are the fibroblasts, they make fibrin, and they promote fibrosis. This can progress. If the exposure to the alcohol continues, you can go from steatohepatitis, fatty liver, through fibrosis, all the way to cirrhosis, and then in extreme cases, this can develop all the way to hepatocellular carcinoma. About a quarter of liver transplants are due to this, and why not more is, in order to be a candidate for a liver transplant, one has to be considered a good steward of the liver that's being donated, and somebody who has a chronic problem with alcohol consumption. It's hard for them to become candidates for a liver transplant. Okay, and then finally, the final topic is non-alcoholic fatty liver disease. So we see some of the same symptoms that we see with alcoholic liver diseases, this fatty liver, you know, the deposition of fat in the liver, and the person might not touch alcohol at all. It's highly associated with obesity, diabetes, and metabolic syndrome. And what we're finding a lot is, although it's fat that's being built up, it's not fat in the diet that's creating the problem. It's the excess energy that's being consumed largely in the form of carbohydrate. And that's leading to the fatty liver disease. Fatty acids are made in the liver, but the secretion is inhibited, and so the fat stays in the liver. As with the alcohol, if the alcohol can be eliminated from the diet, some of the damage may be reversible if it's stopped early enough. The same goes for non-alcoholic fatty liver disease. If the person's can successfully make some lifestyle adjustments so that they can maybe help reverse their type 2 diabetes, help reverse the obesity. Some medications, bariatric surgery can help this significantly. They can help reverse this process. And again, if it's caught early enough, then the damage can be reversed, and the person does not have to live with cirrhosis for the rest of their lives. And that brings us to the end of the chapter on the liver. Have a great week.